today's focus is really about personalized approaches
Mhm.
to care. And when it comes to menopause, there's no one size fits all solution. How do you approach personalizing treatment for each woman? And I am thinking also about sort of the impact of MHT in that conversation.
Yeah. So I always lead off with, what do we know that we have things that menopause hormone therapy is approved for? Okay. It is approved for by the Food and Drug Administration for treatment of severe vasomotor symptoms. Okay. So hot flashes, night sweats, and palpitations actually are now recognized as part of vasomotor symptoms. It is approved for prevention and treatment of osteoporosis. Okay. It is approved for a patient who has premature ovarian insufficiency, and it's much higher doses than MHT. We need to get them to their premenopausal levels, not their post, and MHT is much lower than what we would get in our premenopausal years. And so, but there are things that we know that when we look at observational studies and population studies, that women on MHT have a lower all-cause mortality versus those who aren't. So these are the things I'll discuss with my patients. Like, what do we know? What is it approved for? Okay. What do we know it might do for you? No guarantees,
Right.
and we have to look at her age. So we know that women who start hormone therapy close to their menopause within the first 10 years or before the age of 60 could have a cardiovascular benefit. On average, women on MHT have lower cardiovascular disease in the form of atherosclerotic plaques and heart attacks and death from heart attacks than women who are not offered it. So there seems to be something protective there, especially, in that younger population. So I'm going to discuss those things with her. We talk about her symptoms. We look at her age. We look at her family history. We look at her, potential risks and benefits for her. And then we begin a discussion. Is this something she's interested in? Would she like to begin a discussion on hormone therapy? So I always start in my clinic with estradiol. That is kind of what's been the most studied, where we know most of the benefits is not allowing your body to be away from estradiol. What could that potentially do for you? It's always going to protect your bones. you know, Early in the course of your menopause, it's likely to be protective for cardiovascular disease and maybe, decrease. So that's the number one thing women die from, is
Right.
cardiovascular disease. So we have a serious discussion around that. We, talk about her symptoms, her libido, her, sexual function, her vaginal dryness, her, what do we know? Maybe topical or local estrogen would be helpful for her if she has genital urinary syndrome, vaginal atrophy, pain with intercourse. We go through all of that. If she has low libido, and we in my clinic we do a very aggressive sexual function screening. And
Mm.
so, does she have a good relationship? Is she having pain? Is this an arousal disorder? Can she orgasm? Did she used to have a good libido with this partner and something has changed? This is how we determine who's a good candidate to consider either testosterone, which the Menopause Society has said is a good idea, a good option, or one of the other FDA approved medications. Testosterone is not FDA approved for this,
Right.
right? We use it off label, but there are two, Addyi and Vyleesi. So we talk about those medications and how those may be helpful. In my clinic, I have a body scanner. I'm looking at visceral fat, muscle mass, pre-diabetes. I'm doing extensive screening. And there are patients who are good candidates for GLP-1s,
Mhm.
who are pre-diabetic. We talk about metformin versus GLP-1s and side effects and stuff. So, menopause care. And then, that's just the pharmacology stuff. Okay.
Right.
We talk about non-hormonal options, Veoza, and different medications that we use just for hot flashes. She may not want hormone therapy, or she
Mm.
may not be a candidate because of a contraindication. We go through the other medications that may be helpful, but we have to break it up into symptoms, right?
Yeah.
And so if she's got osteopenia, osteoporosis, what do we know would be helpful for that? in my clinic, again, I have an hour with my patients. We do a lot of nutrition counseling. We are talking about processed foods. We are talking about anti-inflammatory nutrition. We are giving them meal plans. And I have a background in nutrition, so I'm able to do that for them. We talk about exercise. Most of my patients are at least walking. I try to meet them where they are. If they're sedentary, I'm like, can you give me 30 minutes, 5 days a week for walking? We can cut your risk of type 2 diabetes by doing 30-minute walks after dinner every day. Um, and if they're already walking, I encourage them to get a weighted vest. We talk about resistance training, adding in resistance training as they become healthier, how important it is to keep your bones and muscles strong. We talk about supplements. I encourage them to download a free nutrition tracker. We're looking at fiber intake, vitamin D, magnesium. Are they meeting the FDA minimum for that? We give them very aggressive protein goals, given protein is so protective of our bones and muscles, and most women are not getting adequate protein for that amount. So, that's when I talk about personalization, we're doing the whole toolkit. Pharmacology, supplements, nutrition, exercise. We talk about stress reduction. We talk about sleep optimization, getting the room cool enough, getting good sheets, getting a good pillow, all the things we need to guarantee. Cutting back on alcohol or doing away with it altogether seems to be the best thing for sleep.
For
So
sure.
for those who struggle with it.